Good afternoon all. I'll be speaking on the old is gold method, that is the contact biometry. Is there a role still? Yes, I would say there is a role still. What is a biometry? It is just applying your math to the biology. Nowadays, a cataract surgery is no longer a cataract surgery. It's a refractive surgery too. So all the patients who come to us will demand unaided 6x6 or N6 vision. So the most common cause of the dissatisfaction in these patients is because of residual refractive error, which is remnant after your cataract surgery. So the key is having a precise IOL power calculation would make the patient happy and would not give any residual refractive error. So now the question comes, which biometry to use? So we have a lot of biometry devices in the market, from the ultrasound biometry to the optical biometry, the immersion, the contact or the applanation, and a various number of optical biometry which uses different principles like PCA, swept source, and SDOCT, and OLCRA, so many principles. So basic requirement for any IOL power calculation is your axial length power, the corneal central axial length, central corneal power, and the anterior chamber depth, which can be easily given by a contact biometry also. The rest of the things are the accessories, like your lens thickness, the effective lens position, the white to white, or your corneal thickness. So this is a chart which is taken from the JCRS journal, which gives us the input of prediction of errors according to different parameters used. The effective lens position contributes to the maximum, which is basically a post-surgical outcome. The other two, the axial length or the keratometry measurements, can be acquired by our contact biometry too. So this is another chart which reflects the post-operative IOL errors, which contributes the most. Like the difference, like 1 mm difference in the corneal radius and the axial length contributes the most to it. And this is what is very important when we do any biometry. To take care, we get the proper axial length and corneal radius without getting any corneal compression. So these are few studies which say like this is the contact versus immersion biometry study where there is no significant difference in the axial length measured by either of them, either using either of the devices or the techniques, and also ocular ultrasonic using contact A method with optical biometry. Here also the significant difference in the axial length was very less. So we have our own in-house study which is yet to be published of 300 patients operated by 2 surgeons of 5 years of experience in the 6 months, and almost 90% of the cases we had post-operative refractive error of spherical equivalent less than 1 diopter. So you can just have a scan printout if a surgeon himself is not doing, which shows all the parameters like the SD and the scans, all the correct amplitude scans and all, so that there'll be no chances of error or any compression. So the next thing is, there is another survey which was done in in UK, which was the common source of mistake which contributed to the A-scan biometry, and 90% was the human error, and 10% was the machine or the technical error. So the human error could be wrong A constant selected, wrong formula used, wrong K readings entered by hand, or wrong eye biometry. So I would just go through few cases for which I used the contact biometry in spite of having the optical biometry, which gave me a similar good results. So this is a case of mature cataract, and I tried to do a optical biometry. We did not get any scan there. And then with the contact biometry, I went ahead implanting the chosen IOL power. The post-operative refraction at 4 weeks was -0.5 at 90 degrees, which was an acceptable thing. Second thing, the patient had a kyphosis where I could not make the patient lie down. So again, using immersion was a little difficult in this case. So I had to go ahead with the contact thing. In case of very thick PSC, here also I did get a optical biometry reading, but it was very erroneous. Like it showed around 28 and 30, which was not acceptable. And I went ahead with the old is gold method, and then implanted the IOL, which gave me a very reasonable post-operative error. So I would just go through few tips and tricks to get the accurate A-scan reading. First thing is the position of the patient. Always, you can make the patient sit straight or lie down supine without any pillow support below. And fixation of the patient is very important. Keep the other hand or other finger of the patient fixating, or the light coming from the A-scan probe as a fixating modality. Always hold the fixation probe from the wire and not the probe itself. Second thing is, you just apply a small drop of any topical anesthetic. Do not flood it with any antibiotic drops or CMC, whichever you're using. Just a small, very small layer of a fluid of antibiotic would be enough. Very important thing is to get the 5 amplitudes, the 100% amplitudes of the 5 amplitudes. The first one will be the combined anterior and posterior surface of the cornea. Then you will have the lens amplitude. And then you need to have your retina spike, which takes a sharp 90-degree bend, and followed by it, you should have a discrete scleral spike. So there should be a gap between your retina and scleral spike, and then the falling of your orbital tissue. So those amplitudes are very important. It's always, I would always say, better surgeon does it, whoever is operating to do it. If not, get a scan like this, which is shown there, so that at least you can know the technician has got the proper amplitude scan. Use appropriate mode, and also very important is when in IOL, certain IOLs, you will have different optical A constant for optical and ultrasound. So use it appropriately when you're interchanging, like when you take optical for K readings and axial length, you use your ultrasound. Use it appropriately so that you don't get an surprise, a refractive surprise. Gain, always don't do trial and error method. The picture on the right side, gain is high. Decrease it till you get a discrete amplitude. Like you have to see discrete retina and scleral spike, and then the appropriate gain is chosen. Again, always center of fixation. Foveal fixation is very important. Misalignment would lead to absence of spikes. Corneal compression, they do not average it. Take different, see the scans individually and then choose it. So in special cases where there is posterior staphyloma, always do a B scan to confirm the relationship of staphyloma to macula. And in case of vitreous hemorrhage or asteroid hyalosis, there might be additional spikes. Do not get confused to it. So to conclude, I would say there is still role of contact A-scan biometry if all the above mentioned points are kept in mind. And in a tier 2 city practice with high volume cataract surgery, it's of great help. Provided a trained person does it, a surgeon himself chooses the amplitudes and scan. I would always say old is gold. Even though you have an optical biometry, always don't throw away your A-scan biometry. So my mentor used to say, using a surgeon who spends more time in biometry calculation rather than the surgery would have a very happy patient. So thank you.
While measuring with contact scan, whether 0.25 millimeter should be added in all cases?
Sir, sorry.
Compensate for the compression with the probe.
Yeah.
Some recommend 0.25 millimeter length should be added to.
No, sir, we don't use that, thing.
In a two-tier city, you do not need optical biometer. We can, even then we can have this only A scan with the conventional method of immersion method. Yes. So, immersion method is not a costly affair. Even we were doing for last so many years the immersion method, and we compare with the Iyer Master 700 with all the biometry. There was no difference in immersion method and the biometry reading. So in two-tier city also we can do the biometry with the immersion method.
But
contact method is the person difficulty is that one person you have to train lot. That's the sir said ki compression, what factor you are going to do for the compression.
There will be no corneal compression.
And there are in the city.
Same day you cannot do it. Main thing is.
There will be no corneal compression with the immersion method. Yes. Because without immersion, it measures less.
Sir, can I answer that question? If you use a Barrett, online Barrett, if that is the question, actually there nowadays you need not have to use this 0.2. You can just select whether you have taken it by a ultrasound or by an optical biometer. Automatically that uses.
But ultrasound with immersion method or without immersion, that is not in the Barrett formula, na? They ask only whether ultrasound or...
Yes, sir. That is meant for immersion method.
Immersion method. But many doctors, they don't use immersion, just contact is easy. I think then we can add 0.25 millimeter to the axial length.